The Risk of Disasters on the Homeless, EMGT 2454 Disaster Health. Homeless concerns pre-disaster. Homelessness is a problem found in every major city. The root cause of so much of the homeless community living this way is the historic social inequities we have not been able to avoid. Inequalities such as poverty, racism, sexism, erasure of culture and communities, and the general power dynamic of our daily life. To have an upper class, there must be a lower class. Through a lack of shelter and the security it brings, transient populations are at an increased risk for victimization from crime. 92% of women facing some form of abuse, and 83% of homeless children facing serious abuse by age 12. This vulnerability to trauma further isolates and exacerbates any underlying conditions the victims may have and leads to PTSD that may manifest in many psychological and somatic disorders. While mental illness can precede and be an underlying factor in homelessness, it also follows and is birthed by the stress of social exclusion, living without stable shelter, sleep deprivation, and degradation of nutrition that comes with a transient life. The occurrence of serious mental illness within the United States is 1 in 17, and in the homeless community, it is 1 in 3. This staggering statistic is made worse by 2 out of 3 that suffer from some form of addiction, and a 32% rate for men, 37% rate for women, with comorbid illness and substance abuse disorders. Disaster effects on homeless. Keeping in mind the trauma, mental illness, and addiction problems of the homeless community, during disaster, this same community has an increased risk of adverse physical and psychological reactions. While most people can seek shelter in their homes before being evacuated, transient populations are directly exposed to the effects of disasters. Homeless people, as well as lower working class families on fixed incomes, often do not have resources to evacuate when it is called to do so, or available resources to collect needed supplies. Factors during recovery, such as increasing rent prices, unavailability of low-income housing, damage to uninsured homes, and limited rebuilding resources, lead to increases of people who find themselves newly homeless following a disaster. In addition, shelters, organizations, and facilities in place to aid the homeless are often affected by the disaster as well, taking away more of the already limited resources. Compounding these factors is the increased presence in their lives of law enforcement. Police spreading instruction and evacuation orders are not often seen as helping hands, but are treated with distrust by transient people, fearful of arrest. Health needs. Health needs for a homeless population during disaster response and recovery involve availability of resources and services. Firstly, any responders, emergency social services, and health services must assure and ensure the physical safety of the vulnerable victims. Trusted staff with experience in care of sensitive patients with histories of trauma can provide emotional and psychological support through such a trying time. Providing services and easy access to the services, such as domestic abuse hotlines and disaster distress helplines, can offer a sympathetic ear for victims as well as help to increase their sense of safety within the system. Health needs of the homeless cannot be addressed without first ensuring their basic needs are met. Keeping families together provides unity and comfort, while providing food, shelter, and clothing can make someone feel safe and less of a flight risk. Once these needs have been met, screening for trauma, whether historical or disaster related, can verify what medical needs must be met. Offering age-appropriate and gender-specific caseworkers and services can often make sure the victims understand the situation and uncover any underlying issues such as domestic abuse. Services needed. Providing service to the homeless community during a disaster requires additional sensitivity for their particular circumstances. Staffing facilities and services with workers with either experience being homeless themselves or with a history of working with the homeless who can participate in disaster planning to ensure the specific needs of such a vulnerable community are taken into account would be a benefit. Arranging education on trauma, its impact on victims' physical and behavioral health, as well as its triggers, such as loud noises, small spaces, lack of privacy, chaotic or disorganized surroundings, can increase the success of services to reach and establish trust from the homeless community. Services are needed to keep people safe and to keep families together throughout disaster response and into recovery. Keeping in mind that a significant history of trauma often exists from before the disaster, and recent events may exacerbate any underlying issues. Follow-up care should be made available throughout recovery to ensure that the effects of disaster do not compound other issues such as previous PTSD. Facilities are needed with the ability to go into an overflow mode to accommodate the influx of people, relaxing check-in times and making room to accept more of the community than their usual limit. In Houston, it is estimated that some shelters operated at above 150% capacity for months following Hurricane Harvey. Additionally, during response, it is beneficial to have deployable street outreach teams to keep the homeless community informed of the current situation, evacuation or additional instructions, or generally to help to spread information that might otherwise not reach them. Having experienced service providers assist and consult relief organizations and emergency management and response agencies such as the Red Cross help those agencies that may lack experience working with such a vulnerable community. Recommendation 1. Increase trauma training. Increasing scope and depth of training in a trauma-informed approach for service providers also increases sensitivity to trauma. This can improve communication between staff and victims, facilitating compliance and increasing impact of services. Disaster mental health and crisis counseling differ from therapies in a clinical setting. Additional training to avoid misinterpreting disaster-related stress with symptoms of underlying illness would benefit these populations. Recognitions of signs and symptoms of history of trauma, mental illness, and disaster-related stress in clients, their family, and other staff is integral to providing appropriate services and aid for these problems. Integration of this knowledge and training into how policies, procedures, practices are performed, as well as planning for disasters, instills the importance of this training and its positive effect on the homeless community during disaster response recovery. Recommendation 2. Integrated addiction services. Disasters displace not only individuals and families, but also many services. People in treatment programs or using street drugs can experience interruptions due to a disaster, compounding issues with withdrawal and stress. Connection with treatment programs should be made as soon as possible, connecting patients with appropriate facilities. Part of appropriate connections requires training to recognize the difference between mental health issues, addictions, withdrawals, and their combinations. When concurrent disorders are present, substance abuse can, quote, cause psychiatric symptoms and mimic psychiatric disorders. Substance use can initiate or exacerbate a psychiatric disorder. Substance use can mask psychiatric symptoms and syndromes. Withdrawal from substance can cause psychiatric symptoms and mimic psychiatric syndromes. Psychiatric and substance use disorders can coexist independently. Behaviors related to psychiatric symptoms can mimic substance use problems. Eddington, 2009, end quote. It may not be possible to isolate problems in comorbid health issues among the homeless during a disaster. Integration of care models to include mental health facilities and addiction services in one location optimizes treatment by enabling access to clinicians for mental health issues, addiction, and recovery, as well as case managers to arrange any additional specialized treatment or shelters. Recommendation 3. Fund chronic and acute medical services. With acute and chronic health conditions 3 to 6 times greater than other communities, factors such as exposure to the elements, living in tight quarters, in shelters and camps, poor hygiene, high-risk behaviors, inadequate nutrition, and lack of access to sufficient health services and in privatized healthcare systems insurance, all contribute to the disparity in health between homeless communities and those with stable housing. Acute illness accounts for approximately 2/3 of homeless health problems. Illnesses such as respiratory infections, like influenza and pneumonia, and physical trauma, such as wounds, fractures, and burns. The other 1/3 of health problems within the homeless community is made up of chronic conditions such as hypertension, neurological disorders such as seizures, and respiratory conditions such as COPD. Instances of concurrent physical and behavioral health conditions receiving treatment at healthcare for homeless sites are as high as 70%. Such a plethora of possible health issues requires increased funding and resource allocation for the significant training and employment of experienced service providers to staff clinics and sites to identify, report, and assist in health issues. This allows for proper diagnosis and care of conditions. Health sites should not be limited to on-site care, but also act as distribution points for pharmaceuticals, supplies such as bandages, and vaccination centers to ensure the community gets adequate care once they leave the site. Finally, the increased funding to staff health centers for the homeless would allow sites to distribute and provide health and disaster information, ensure the data is translated and understood in an accessible way, and communicate the risk of individuals' health problems as well as how they might be affected during disasters and what must be done. In closing, during a disaster, the priority for everyone, whether homeless or not, is to ensure their safety, unity of their families, and fulfill their immediate needs for food, safe shelter, clothing, and any necessary medical treatments. This can be made difficult when serving people from the homeless community due to the many issues they have, such as high rates of trauma, mental and physical illness, substance abuse, and addictions, all of which can be heightened during a disaster. By increasing training to identify previous trauma, integration of addiction services, and increases to funding and expertise of staff at medical and health care for homeless centers, we can aid in the recovery of our society's most vulnerable community.